Physiology post PCI, the new gold standard. I'm Abdul Hakim. I'm an interventional cardiologist at Rutgers Robert Wood Johnson Medical School in New Brunswick. I'd like to thank the organizers for inviting me to put this talk together. I do not have any disclosures. So traditionally, how is the success of PCI defined? According to the American College of Cardiology and the Heart Association guidelines, it's technical success that is defined by angiography after stenting, where a minimum stenosis diameter reduction to less than 20% has been the traditional clinical benchmark of an optimal angiographic result. Other tools like IVIS and OCT have been used to confirm adequate stent expansion and define a minimal stent area. The guidelines further define success as procedural success, where one achieves technical success without in-hospital MACE, and then clinical success is defined by a procedural success with resolution of signs and symptoms of ischemia. So the obvious question then is, how successful is PCI in eliminating ischemia? Multiple studies have been done. I would like to share a few with you in this context. This is a study we published about 4 years ago, where approximately 600 patients with 650 lesions underwent ischemia-driven PCI based on an abnormal FFR. And once there was technical success based on angiography, FFR was remeasured. And as you can see, approximately 20% patients, despite having angiographically successful PCI, had persistent ischemia. More recently, the defined PCI investigators, led by Dr. Jeremias, showed that after successful or technically successful PCI as measured on angiographic grounds, approximately 23 to 24% patients will have residual ischemia as defined by post-PCI IFR of less than 0.90. Why is this important? Post-PCI FFR has been linked to long-term outcomes. This is an extremely important publication by Dr. Johnson, who looked at individual patient level data from multiple studies and found that the lowest tertile of post-PCI FFR had a significantly high event rate at 3-year follow-up compared with patients who were in the middle or the highest tertile. Furthermore, it has come to light that the degree of FFR improvement, i.e. post-PCI FFR minus PCI FFR or delta FFR, is associated with long-term outcomes. This is a fairly recent publication from the FAME group, where data from FAME1 and FAME2 on subjects who underwent post-PCI FFR was analyzed, and the authors demonstrated that the higher the delta FFR, the lower the vessel-oriented clinical events. Furthermore, the change in FFR or the delta FFR was directly related to angina relief at follow-up and was inversely related to vessel-oriented clinical events. Again, as somewhat of an extension of the concept, the Orbita investigators, while demonstrating that PCI was no better than a sham procedure in relief of angina or exercise time, did demonstrate that the stress test score, or the degree of ischemia based on stress tests, was directly linked to angina relief, such that patients who had a high stress test score, if they underwent PCI, they had significant angina relief compared to a sham control procedure. And it is important to note that in this study, the stress test score was directly or almost exponentially linked with the degree of FFR. So the more ischemic the FFR, the higher the stress test score. So it would be important to extrapolate that the degree of ischemia at baseline predicts the anginal burden and a higher stress test score, and the more relief one gets, the better is the degree of angina relief. Another study by Dr. Lee's group demonstrated a similar concept, where they showed that not only was the final FFR predictive of MACE, but also the percent change in FFR, i.e. the degree of ischemia reduction, was directly linked to clinical outcomes. So patients who had higher percent FFR increase had a significantly lower event rate compared to patients who had lower degree of ischemia reduction. So the question then is, if post-PCI FFR predicts MACE, can anything be done to improve it after it is found to be low or suboptimal after angiographically successful PCI? We demonstrated that in about 650 lesions where, as I described before, 1 out of 5 lesions were persistently ischemic post-PCI. If further interventions were undertaken, including post-dilation, stenting, a combination of the two, or further evaluation is IVUS or OCT, the overall hemodynamic profile could be significantly improved, such that there were 20% patients who had 18 to 20% patients who had persistent ischemia after technical success based on angiography. When further interventions were undertaken, this number was brought down to less than 8%. Another important concept from the study was that relative to where FFR was measured on pullback, the degree of ischemia had a differential impact, such that patients who had a correctable cause, i.e. An issue with a stent or a second lesion, these patients were able to have significant improvement in ischemia compared to patients who had persistently abnormal FFR in the very distal vessel, which would be attributable to fixed diffuse disease that is not technically amenable to further intervention. We recently demonstrated this in a prospective registry of 250 patients, with a majority being in the severely stenotic range, and majority having severe ischemia baseline FFR, and post-PCI they had significant improvement. However, 36% of these patients had significant ischemia. A third of these 36% patients underwent subsequent intervention with an improvement in FFR. An important concept that was tested here was that a third of these could be fixed, but 2/3 of persistent ischemia is related to diffuse distal disease that cannot be technically addressed. So this brings us to another important concept of differential physiologic response after PCI. This is a nice schematic diagram by Dr. Lee's group that show 4 patient categories based on post-PCI FFR. There are patients who have a healthy looking artery except for a very focal type A lesion that is very tight. These patients will have a very low pre-PCI FFR. Once stenting is done, they will have a high post-PCI FFR and a high percent FFR increase or significant ischemia reduction, and these patients tend to have the most benefit out of PCI. Then there is the patient subset, which probably is majority of the patients that we treat, where there is a high-grade lesion, but there is also a moderate diffuse disease in the distal vascular bed. These patients will have a high percent FFR increase, but would have a low post-PCI FFR on account of the diffuse distal disease. Then there's this patient who has a moderate focal stenosis where the FFR is fairly borderline in the 0.78 to 0.79 range. PCI is performed, FFR increases to 0.91, 0.92. These patients do have a high post-PCI FFR, but the degree of ischemia reduction is relatively low. And finally, there's a patient who has predominant diffuse disease, and on top of that there is a intermediate lesion where the pre-PCI FFR is low, the focal lesion is treated, and the post-PCI FFR continues to stay low, and no further interventions can decrease that FFR or increase that FFR further. There's been a lot of enthusiasm about the non-hyperemic pressure ratios. I already shared with you the DEFINE PCI study by Dr. Jeremias. We looked at post-PCI PDPA and demonstrated that it was equally efficacious in predicting long-term outcomes, and post-PCI PDPA could be used as an alternate to FFR in defining the physiological success of percutaneous revascularization. So what are the major causes of ischemic post-PCI FFR? As I've discussed, diffuse disease is the most important cause. You have a residual minor stenosis in the setting of diffuse disease. Then there are causes that can be fixed, like an underexpanded stent, a geographic misc of the culprit lesion, an edge dissection. There are other causes like large collateral supply by the index artery to a CTO territory, myocardial bridging, and these cannot be fixed with further intervention. Be mindful of technical causes like pressure drift, vasospasm, extreme vessel tortuosity that causes a wire bias artifact or an accordion effect. The question then is, what is the optimal post-PCI FFR one should aim for? Different studies have demonstrated different predictive thresholds. This has to do with the duration of follow-up and the complexity of patient enrolled. Studies with shorter duration of follow-up and relatively low risk patients with simple lesions demonstrated higher predictive threshold compared to patients with longer term follow-up and more complex lesions demonstrated a lower threshold. I think evaluating post-PCI as a continuous variable and looking at the degree of ischemia reduction is more appropriate when it comes to risk stratifying patients and looking at the clinical benefit of the procedure. So this brings us to this concept of functionally optimized coronary intervention, or FCI, where ischemia-based PCI is performed. Once technical success is obtained and geographically ischemia resolution is confirmed by post-PCI FFR, a pullback is performed to exclude the causes of suboptimal FFR, and importantly to make sure there is no drift. Once there's no drift and there is suboptimal FFR, the different mechanisms should be defined. If on pullback the mechanism cannot be defined, IVUS OCT should be undertaken, and FFR should then be measured after subsequent intervention. So in conclusion then, after angiographic optimization, post-PCI FFR is in the ischemic or low normal range in a significant proportion of patients. A higher post-PCI FFR is associated with decreased MACE, such that higher is better. In patients who have an angiographically successful PCI result but low post-PCI FFR, further interventions can be taken at the time of the index procedure to improve final FFR. Post-PCI physiology should then be the target functional endpoint of defining successful revascularization. Thank you.